there is a philosophy, I guess, that we embrace, that if you're concerned about protecting people's privacy and giving you and I and our families control over our health destiny and our health information, you've got to design that idea in from the beginning. You can't say we're going to build a beautiful, elegant electronic database in Bethesda somewhere, and then we'll worry about protecting people's privacy, or then we'll worry about how they have control over it, or then we'll worry about data mining, and then we'll worry about identity theft. You've got to think about that today. And you got to decide what kind of technology to build and what kind of architecture to build because you want to achieve social objectives, policy objectives. And that's why I shared Susan's point that it's very important that this discussion happen now before people start building big databases and deciding how they're going to work. So the architecture of the system will determine the policies that Americans will have to live with and which will affect their privacy and their control and the potential uses or misuses of their data. Now, the model that Connecting for Health developed over a few years is something like this. First of all, another bit of arcana, the NHIN, the National Health Information Network, or Nationwide Health Information Network, and that's a whole debate by itself. The NHIN is the shorthand term for how do you tie all this stuff together so that across the entire United States, any piece of health information can be retrieved and made available where it's needed. The next bit of jargon on this slide, SNO, is a term for, we use it for sub-network organization. So if the whole nation has one network, and you live in San Diego, maybe San Diego has a sub-network. It's a sub-part of the whole national network. So you can imagine a San Diego network and a Sacramento network and a Dallas network, or you can imagine a pharmacy network, or a cancer care network, or a disability network, which is another network among the many networks across the country. Now, how do we tie these networks together so they can share information with each other and retrieve a pharmacy record and send it to San Diego or send it back to Medicare? How do you tie these together? That's the challenge we've tried to think about. In this little picture, there are 3 networks, sub-networks. You can imagine them as geographies or as business affinity groups. What we have said is they can do whatever they want within their network. If you're Walgreens and you have 1,000 Walgreens stores, you can build your network any way you want. If you're San Diego and all the hospitals in San Diego want to do something, they can do whatever they want that makes sense for San Diego. We are not going to try to prescribe at a national level what every computer network in healthcare has to do to solve its own local business or policy objectives. And in fact, many of these already exist, and we can't go back and tell them what to do. Instead, what we've said is they have to do 2 things, or maybe 3, in common in order to talk to each other and share information with each other. They have to have what on this picture is called an RLS, a record locator service, which is an index. It's simply an index that says where all the records for David Lansky are located. So if there's a San Diego index, it'll say some of them are in this hospital, and some in that hospital, and some in this pharmacy, and some in that laboratory, and perhaps some in this personal health record, which is available to the network. So the index points to where data is, but does not have the data in it. So from a privacy protective point of view, if someone hacks into the index, all they can get is a list of people's names, dates of birth, genders, and where their records are located. They don't know what's in those records, what test results have occurred, what conditions they may have, or anything else that discloses their health status. That's part of this design. There are others who disagree with that and think that index should have more data in it about a person's health status or treatments. And that's a policy debate that goes on right now. The second thing every network has to have, in our view, is a bridge to the other networks. This picture calls it an ISB, an inter-SNO bridge. That is a bridge between sub-network organizations, to parse the grammar for you. So those 2 things, if every network in the country had an index that made sense to other indices, they could read each other's index, and they had a bridge to send data out from their network and receive data into their network, then all the networks could talk to each other regardless of what they do internally. And any translation that has to occur would happen in the bridge, in the inter-SNO bridge.